So next topic is management of diabetes in surgical patients. So first question is, how do you manage a diabetic patient having day case surgery? So the Association of Anesthetists of Great Britain and Ireland published guidelines in 2015. Key points are that the glycemic control should be checked at the time of referral for surgery, and comorbidities should be noted and optimized. Patient should be admitted and warned the day of surgery, prioritized in the morning. He should have surgery early in the morning to allow for minimum starvation time. Intraoperative blood glucose target should be 6 to 10 millimole per liter. Patient should be involved in planning their post-operative care. Principles of enhanced recovery should be used to promote early immobilization, create a safe discharge plan for diabetes patients, and the process and outcome should be audited regularly. How do you manage a patient who will only miss one meal? If the patient is diet controlled, a patient should fast as normal. He should check his BM 4 times, and the diabetic team can be conducted if the BM is more than 10 for 24 hours. If the patient is on metformin, this should be taken as normal on the morning of the surgery. A patient controlled with sulfonylurea oral hypoglycemia should omit the morning dose and resume in the evening with a light meal. If the patient is in insulin control, the insulin dose is reduced on the morning of the surgery and resumed once oral diet is recommended. How do you manage patients who will miss more than one meal? These patients need a variable rate intravenous infusion, which now replaces the historic sliding scale. The variable rate intravenous infusion is also preferred in those with type 1 who have not received background insulin, those with poorly controlled diabetes, HbA1c, and most patients with diabetes requiring emergency surgery. The substrate solution is 0.45% NaCl, 5% glucose, and other 0.15% or 0.3% KCl. The dextrose is added to prevent proteolysis, lipolysis, and ketogenesis. Capillary blood glucose should be monitored early during surgery and immediate post-op. WHO surgical safety checklist bundle should be implemented with a greater glucose 6 to 10. Supplement insulin should be given 30 to 60 minutes prior to stopping infusion. How will you manage daily fluid requirement for diabetic patient in the emergency setting? The aim is to provide glucose substrate to prevent proteolysis, lipolysis, ketogenesis, as well as optimize intravascular volume status and maintain the plasma electrolyte within the normal range. For all patients on variable rate intravenous infusion regime, I would prescribe 5% glucose and 0.4% saline with either 20 or 40 millimole of potassium depending on the patient electrolyte status. Diabetic patient need 180 gram of glucose per day and additional KCl to prevent hypokalemia. If the patient is not a variable rate intravenous infusion, I would prescribe Hartmann solution to avoid hyperchloremic metabolic acidosis. What are the metabolic side effects of the starvation and the surgery? Both induce a catabolic state, which is attenuated in diabetic patients on the glucose insulin infusion. So hypoglycemia also stimulates secretion of counter-regulatory hormones and exacerbates the catabolic response. Major surgery causes an increase in the metabolic hormone secretion and inhibition of anabolic hormones like insulin. Type 1 diabetic patients have no insulin secretory capacity and therefore cannot respond to the increased demand for insulin. The type 2 diabetic patients have a pre-existing insulin resistance and limited reserve, which reduces their ability to respond to the increased demand. Thank you.